gynecologist from Chennai. She did her MBBS from Kilpack Medical College and both her internal medicine and endocrinology from the US. And her current position, she is a consultant at Reina's Hospital and Srivikas Center, Chennai, and with a special interest in transgender medicine and transplant endocrinology.
Thank you, Missy. Thank you. I think deja vu madri. Last year, we did chat person. Thank you. Which means I was telling Dr. Kumarvel that I'm here every year. Every August, I come to Madurai. So thank you so much for having me here. And I see the receptor family growing every year. Welcome, Dr. Abraham, to the team as well. So I have this task of talking about primary amenorrhea, the approach to primary amenorrhea in about 20 minutes. So this is a very vast topic to put it all together in 20 minutes. So when I was in fellowship, we have this algorithm-based approach. So pregnancy, rule out pregnancy, even though it's primary amenorrhea, rule out pregnancy. And then in the other approach, we have whether uterus is present or uterus is absent, high FSH, normal FSH, low FSH. But that was very confusing. Actually, any other question I can't tell you that. It's very difficult to just go with, even though all the studies or, if you look at the up-to-date literature, it gives you algorithm on how to approach primary amenorrhea. Putting it in clinical practice is very difficult. So when I was trying to prepare this slide, I should thank my friend, Dr. Bharat. He was glad. He actually shared his presentation on primary amenorrhea. With his permission, I modified the slide deck a little bit. Thank you, Dr. Bharat. I should really acknowledge for this. It's a very simple presentation that he has made, which I'm going to take as a backbone with some clinical case scenarios and present to you, and will give you some important take-home message from the presentation, because it's a very vast topic. In the 20 minutes, I will not be able to cover or discuss about everything. So with that, I will start with this, and I'm also going to end up with the same slide. Amenorrhea is a symptom, not a disease. The final diagnosis should be a pathological diagnosis. When the patient comes and tells us that they don't have their periods or they didn't get their periods, we need to investigate, listen to them, examine them, and then investigate and figure out what is the reason for this. So the final diagnosis should be the one that, we'll take a couple of clinic visits. It takes a lot of discussions between you and your patients, but that would be the pathological diagnosis. எப்படி define பண்றது? So it's defined as a failure to establish spontaneous periodic menstruation by the age 15 or 3 to 5 years. Some guidelines says 3 years, some says 5. Breast development வந்ததுக்கு அப்புறம் somebody fails to have a first period, then it's also called as primary amenorrhea. So by age of 15, if somebody says that I have not got, if the girl child comes to us and say I have not got my cycle, then we need to listen and investigate and evaluate them to figure out the pathological cause for primary amenorrhea. So this is the backbone of the entire presentation. So I'm not going to show you this complicated high FSH, low FSH, present uterus, absent uterus. This is very simple. One, it can be a disorder of the outflow tract, which is primarily dealt by the gynecology colleagues here. Disorders of the ovary. It can be a disorder of the anterior pituitary or the central nervous system, which can be combined together. So in the backbone, I'll give you some clinical scenarios. So 3 patient scenarios, and we'll see how to sort of investigate and what sort of history we should take and how do we fit this into our clinical practice. So with this, I start with patient number 1. So she's an 18-year-old girl. She is brought for absence of first menstrual cycle. No significant history from the patient or the family. She's absolutely normal. Normal breast development. Her Tanner staging is normal. A physical examination shows no obvious pathology. She's a normal looking 18-year-old girl, right? So nothing is there in the physical examination. So when we see kids like this brought to us, we need to ask some of these questions. So some of these slides will come as a repetition depending on the clinical patients that we are talking. Either the most common scenario would be, some of them would say cyclical abdominal pain. அந்த மாதிரி எதுவுமே இந்த பேஷண்ட்க்கு, but obviously we need to do all the tick boxes. Growth chart has to be plotted. When did the first breast bud or first breast எப்போ notice பண்ணாங்கன்றது கேட்கணும். So all these checklists have to be covered. But in this scenario here, she didn't have any of cyclical abdominal pain. And in examination, this is, as I told you, primarily dealt by a gynecology colleague. The depth of vagina, or if there is any intact hymen, the bluish bulging membrane, the so-called cryptomenorrhea, will have to be ruled out, right? In addition to the other examination that we generally do. So this will be more pertaining because she's a normal looking girl. There is no obvious hormone abnormality. Her growth chart is also normal, right? So what could this be? So this, if you see somebody like this would be a disorder of the outflow tract. So there is something problem there. So the periods is not coming, the menstruation is not happening. So I have underlined. So as I told you, I will not be able to cover all of these in like 20 minutes. It's not possible. Now, underline pannirukena, this is the most common thing that you would see in your practice. Again, this would differ from one where you practice, whether it's a tertiary care center or your practice setup kekamari idu maarum. Mullerian agenesis is the most common. I'll show you the prevalence of all the other at the end of my presentation. But this is a very common cause for outflow tract where you don't have the uterus, or the vagina can be a blind vaginal pouch, or it can be associated with other skeleton abnormality like scoliosis. Idle nariya variations in Mullerian agenesis. So this is the common thing. The other ones would be imperforate hymen. It could be a transverse vaginal septum, cervical agenesis, or in places where you practice, if tuberculosis is very common, you could have a pelvic tuberculosis. Adanala or Adarshans Ashermans the child could not have her first menstrual cycle. So that's why, as I said, it could differ from where you practice. I also see androgen insensitivity. I have 6 or 7 androgen insensitivity because I do also do transgender medicine. Sometimes the DST comes along with transgender medicine. But apdi paatona kuda androgen insensitivity syndrome is something the child will be born and raised as a female. At the puberty, they will know that there is no menstruation because of an androgen receptor problem. So the testosterone is not working effectively. So the child doesn't get her first menstrual cycle, right? So, and you also have 5-alpha reductase deficiency where you could have a progressive virilization during puberty. This is where you really need the chromosomal analysis to figure out why is this happening, right? So this would be broadly, if you classify it as a disorder of outflow tract, this is what could be the reason for primary amenorrhea. In this child that I presented, she had Mullerian agenesis, or the MRKH syndrome that we have read during our medical school and fellowship. That is what she had. And we will not deal in detail about the treatment because, as I told you, it will be very elaborate. But surgical correction for disorders of the outflow tract, gonadectomy, when to do gonadectomy in androgen insensitivity is a big question. You need a lot of law and regulations are there to when to operate on those patients. That's not the topic for discussion today. And the most important thing here for any primary amenorrhea evaluation and management is it needs a lot of discussion. They will come with Amma, Perima, Peripa, Party, ellarum varuvanga room kulla. They'll be like, entire family will be anxious, for that girl. From that point of view, it's a very big diagnosis for the family, right? I think that is where you really need the diagnosis. Of course, you can take 1 or 2 visits. You can go read at home and figure out what to do and come to the pathological diagnosis. But discussion with the family, the psychological, emotional support is the most difficult thing. I think in general, in primary amenorrhea or any of the endocrine or non-endocrine related issues as well, I think that is the most important part that I want to stress here. So then I move on to clinical patient number 2. So that was an outflow tract abnormality. Here a 17-year-old girl is brought again for absence of menstruation. She noticed breast development at 11 years. Adukapra perisa change illa. Tan is 2, 3 liye breed stop. She also has short stature. It's very obvious. She's small. She's a small kid. And no growth chart available. Previously, any growth chart mein illa. Tannis, as I told you, no pubic or axillary hair, no signs of virilization. I'll give you the gist of it. So she has an elevated FSH and LH and no estradiol. I will also finish the evaluation for you. She had a karyotype analysis which came out as Turner's, and we did a pelvic ultrasound which showed a streak ovary. So this was again all these things took 2 or 3 clinic visits, but I'm just summarizing in the interest of the time here. Here again, from the history, it's very important to confirm the age by date of birth. Growth chart is very, very important. Turnus, we can't miss Turnus. The second most common or the first most common cause for primary amenorrhea is gonadal dysgenesis reported. And Turnus is very, very common. So, growth chart, very important. We have to address the growth. The pubertal induction, so it's very important we need the growth chart. And then age of onset of pillar K, all these things, prior radiotherapy. I have about 5 or 6 patients from Cancer Institute who are on hormone replacement therapy after a leukemia and the blood cancer treatment. So history of radiation therapy is very important when you take that into consideration. So Ella tick boxes, so we have to do when we see the history. And here again, Tanner's staging and features of Tanner's should be obvious. Growth chart again will tell you that the other Tanner's features have to be taken into accounts as well. So in terms of hormone evaluation, this is a simplified version of it. You do the basic hormones here, FSH, LH, prolactin, estradiol, TFT. The Western guidelines also says HCG to be done to rule out pregnancy, even though we know ovulation can sometimes happen before the onset of first menstrual cycle. But here, pertaining to the case here, so she had what this girl turned out to be was a ovarian insufficiency or a gonadal dysgenesis because of Turner syndrome. Right? She was a 45X0 Turner syndrome, and this is a simple pathway of identifying whether what could be the cause. So இதெல்லாம் clinical examination history ஓரளவுக்கு சொல்ல முடியும். MD house மாதிரி உள்ள patient வரும்போதே ஓரளவுக்கு நமக்கு தெரியும். Right? So எந்த காஸ்னால இருக்கு. அப்புறம் we can do the investigation, imaging. There's no urgency to do all of these at one go, and I think that's the beauty of endocrinology. History, physical examination, biochemical evaluation, and then radiological evaluation, which is very, very, very important. So all these can be done as a sequence, and this came out as a disorders of the ovary. In terms of disorders of the ovary, the common thing that we would see is Turner's. Can't miss that for the postgraduate students. Please don't miss Turner's. Plotted in the growth chart. Look at the whole growth chart. It's very important. Apart from that, you can have the other conditions that are mentioned here as well. It's also important to know, Guru just presented on PCOS. PCOS can also be one of the cause for primary amenorrhea. The incidence is 7 to 10%. PCOS girls can present to you not just with irregular cycles and the other features of hyperandrogenism, but they can present to you with primary amenorrhea. So PCOS, you primary amenorrhea varala. So where the weight loss, exercise, lifestyle, proper sleep, all those things will make a big difference. So these could be broadly the disorders of ovary which can present as primary amenorrhea. But endodontic practice, most of the endocrinologists here in the audience would agree that gonadal dysgenesis and Turner's probably the common thing that we see. The other things are also listed there in terms of CAH and Cushing's and other causes. So just a few words on Turner's. So very slow pubertal induction, very chance of autoimmunity. So you have to screen them periodically for diabetes, thyroid and other autoimmune conditions. Cardiac evaluation. I have 2 Turners who went through pregnancy last year through in vitro fertilization. So one of them had a cardiac problem as well, which was taken care by the cardiologist. So it's very important we do all of those things before we actually, diagnose, and also when they plan for pregnancy and everything. Growth hormone therapy is very important, and explore the fertility options. It's something which is very necessary. So I have, this is my last patient. I have a few more slides and I'm done after this. So she's a 15-year-old girl from London. So she has absence of periods. So both her parents are physicians. So they are practicing in the UK. So she has secondary sexual characters. TANS 3, I would say, for the breast. TANS 2 for pubic hair. Growth chart is absolutely normal. Her hormone evaluation shows low estradiol and low gonadotropin hormone. Other pituitary hormones are normal. So this looks like more like a central problem. Indian problem madri irukku. So something wrong with the pituitary. Could be a gonadal, it could be a hypothalamic problem where she still hasn't got her first menstrual cycle. Obviously, the parents are very concerned because her younger sister, she's only like 11 years old and she went through puberty. And she's 15 years old and she has not gotten. And now we know the age of puberty has changed. So they are very concerned that she still hasn't gotten her first menstrual cycle yet. So when we see like this, of course we also look for the bone age for any constitutional delay. In the end, it's very difficult as an endocrinologist to know what to tell, whether it's a constitutional delay or hypogonadotropic hypogonadism. What should we do? It's a very tough call. Only, we have periodic follow-up of these patients. Kids could really tell us what this is. Here, the MRI pituitary was done after the biochemical evaluation, which also turned out to be normal. But at this point of time, we decided to wait. I didn't really give her they didn't want to go start her on hormones yet. They wanted to wait. So this could be, in the value of profile, it could be a disorder of anterior pituitary or it could be a disorder of the central nervous system. Right? Here, the most common thing here that has been reported in 5 to 10% is isolated FSH deficiency or hyperprolactinemia I would say I have about three kids presenting with hyperprolactinemia, prolactinoma, presenting with primary amenorrhea. So we have to keep into consideration. So it can be congenital hypopituitarism and all the other reasons that have been listed here. And in the central nervous system, of course, we all know Kalman syndrome, and then the sense of the smell, தெரியுதான் கேட்கிறோம். So then we have genetic studies for that as well. Anorexia has become very, very common. Right? In the cycle எப்படி பார்க்கணும்னா, we have PCOD features. They say, அம்மா நீ வெயிட்டை குறைக்கணும். That's all they say. And they go to this excessive weight loss effort. They work out like crazy. They stop eating. அந்த மாதிரி நிறைய kids they come. That's mostly secondary amenorrhea, but here again it can present as primary amenorrhea as well, where the periods completely stop. So it's very important how we tell them to lose weight, because we don't want this excessive weight gain, weight loss that is going to affect the hypothalamic pituitary axis, and the periods will completely stop. So extreme exercise, stress, marathon runners, it's very common for them to have a irregular cycle. Again, this can present as secondary amenorrhea or it can present as primary amenorrhea in a child as well. So again, as I told you, in constitutional delay, intermittent withdrawal of HRT to look for a spontaneous cycle can be done, and follow-up is the way to differentiate both these conditions. The broader principle is, if you put them on hormones, say it could be Turner's, or it could be a pituitary hormone or a central hypogonadotropic hypogonadism, start slow and go slow is the approach that we follow. But even though the family wants to do that first ceremony, they want the periods to come immediately, right? So that they can celebrate it at home. We tell them that that's not the way to go. We have to do a slow estrogen induction and then start progesterone. And that is pretty much what we do in our transgender patients as well. We go very slow and up titrate the dose. So here again, it's a very slow hormone induction is what we do. Oral contraceptive pills are something that we would never start these patients on. Start with lower estrogen therapy. Give them only then the size of the breast, the secondary sexual characters will be formed beautifully for the child. So there's no hurry. So I usually tell my patients that நீங்க எவ்வளவு அவசரப்பட்டாலும் it will take இவ்வளவு வருஷமாவது ஆகும். So நீங்க வேணும்னா வீட்ல செலிப்ரேட் பண்ணிக்கோங்க, but I will do it my way only. I will not do it, give you an oral contraceptive pill and let the child go through the first menstrual cycle immediately. So in terms of craniopharyngiomas, prolactinomas, in anorexia, counseling and improving the nutritional intake is very important. So this is the broader approach. I think I have about 3 minutes left. So I have 2 last slides for my talk. So putting it all together, right? We talked about so many causes for primary amenorrhea, and we are going to, as a clinician, this is from the all over the world data. This is not my data. This tells you the most common causes for amenorrhea. First common is gonadal dysgenesis. So that's the most common thing. So growth chart, examining the child, looking for Turner's features is very, very important. Mullerian agenesis, absolutely normal looking girl child with absent Mullerian structures presenting as primary amenorrhea. That is the most common second cause that has been reported for primary amenorrhea. Constitutional delay in puberty, that's third. So another, when we see this hypogonadotropic hypogonadism versus this constitutional delay, we don't know what to tell. Whether it should be wait, should we do hormones, should we stop the hormones periodically, see if the axis improves. But this is the most common thing. So sometimes just waiting might induce the cycle. As I told you, 7% PCOS can present as primary amenorrhea. Very important to keep in mind. Isolated GnRH deficiency, transverse vaginal septum, adala coming chances. And again, pelvic tuberculosis, if you're in an area where tuberculosis is very common, you could have pelvic tuberculosis presenting as adhesions coming. It's not reported in the worldwide literature, but Indian data shows that pelvic tuberculosis can present as primary amenorrhea. So it's very important to know what are the common things. So I will finish with this last slide. So I have 1 minute and 30 seconds more. So again, amenorrhea is a symptom, not a disease. The final diagnosis should be a pathological diagnosis. Pathological diagnosis, whatever it could be a Mullerian agenesis, or it could be a Turner's, or it could be anything that you see in your practice, is definitely a dis-ease to the family. It could be when I was in fellowship, when I was training, when we see, patients like this, we used to remember all the syndromes and say all the manifestations. But after practicing for 12 to 14 years, now I realize none of those things matter in practice. What matters is empathy. not knowing the pathway for diagnosis, which I'm sure all of you would pick up at some point. This is for the postgraduate students here sitting here. So what is required here is empathy. How do we communicate this to the family? Which unfortunately the empathy is not taught to us in medical college, but it can be learned from your professors. It can be picked up along your practice. So what you really need is a social, emotional, psychological support. Of course, all the other treatment options are there, but I think this is what is required when we see these kids, not just kids, the entire family with amenorrhea. I think this is what we really need as a clinicians to do and understand and handhold them and give them the time. You know, when I have 10 more seconds. So when I was in fellowship, I didn't have a child when I was in training. வந்தோடனே கேட்பாங்க மேம் குழந்தை கல்யாணம் ஆனா குழந்தை பிறக்குமா. That was the first question they used to ask. Sometimes even why are they even talking about that? We've not even done the diagnosis yet. That's what I used to think. But now my daughter is sitting here in the audience and listening to me talking. And you know, from a parent's perspective, I totally understand what the mother and the grandmother goes through, right? So I think that is the most important thing that I want to communicate to this audience. So leave alone the syndromes, pathways, investigations. You know, what we really need is a social, emotional, and psychological support and empathy to the patients and the heart of hearing to your patients. With that, I conclude and I once again thank the organizers for giving me this opportunity. Thank you.
Thank you, Shruti. As usual, it is a very lucid presentation, beautifully done, and stressing upon the social part of the problem too. But I have one question. I've been listening so long, and you have beautifully put all the causes and their incidents. But for a practicing gynecologist sitting in the OP, do you have any few tests which needs to be done as a baseline test to come to pick up like what could be the cause?
Right. So the basic test would be, ma'am, of course, as a clinical examination in bio lab test matu keeping. Lab test, I would say definitely an FSH. Apart from the clinical examination, growth chart, a thyroid profile. Very rare causes hypothyroidism can present. Central hypohormonal, so thyroid function test, prolactin, FSH, LH. If you want to do an estradiol, the Western guideline says HCG also to be done, but I have not seen any Indian present as pregnancy as primary amenorrhea. So HCG is also included in their guidelines. And if you think of other hypopituitarism, you can do the other pituitary hormone evaluation. But எல்லாத்தையும் ஒண்ணா பண்ண வேண்டாம். But these would be the basic tests that you can do to begin with. And then we can go for imaging, karyotype, whatever is required later.
Thank you for that. But we prefer doing the imaging part first.
I know. Imaging na, even for any cause, like imaging panina, it will come as uterus valarave illa vandrum. Uterus is, it could be a constitutional delay. But if you do an ultrasound, uterus chinada irukku appdi vandrum. The parents get psychologically very worried looking at the ultrasound. Uterus e valarala solitaanga. Uterus needs a stimuli to grow, right? So that's why we don't want an imaging study to be done first. We want it to go through the guideline. That's why we prefer hormone test followed by the imaging to see where we need the imaging. Because in any case, the uterus will be small, and then it just sends a very bad distaste to the family. So Adnan.
Thank you. As gynecologists, we are more worried about the gynecological
I know, the perspective might change. I'm not saying what you do is wrong, what we do is right, but this is something that, this is what I do. But as you said, all investigation பண்ணிட்டு தான் வருவாங்க. அதுல கண்டிப்பா ஒரு ultrasound இருக்கும். Sometimes even go to an extent of MRI also. But usually we see with all the investigations only, but this is the protocol.
Is there any role of growth hormone for short term?
Growth hormone?
Even role of growth hormone short term?
In turners, yes, absolutely. Turners children, if you have a documented turners with short stature, yes, growth hormone is definitely indicated. There is no need to start them on a pubertal hormone right away. Wait, let them get the adequate growth, and then estrogen ஆரம்பிச்சிடும்.
What age will you start estrogen for non-developmental breast? Because at 14 years, if we start epiphyseal fusion will happen. And also, you endocrinologists who are giving equine estrogen. We are used to ethinyl estradiol.
Ethinyl
estrogen is useful for breast development.
We use ethinyl estradiol. I also use. I don't use equine estrogen, so I don't know whether I can comment for your question in that. I mean, Bharat can say, but the ethylene estradiol is what I use. But I usually wait till 16 to start slowly, and then until then evaluate it, and then slow induction is what I generally do. Bharat, do you have anything to say?
Actually, we can use either ethylene estradiol or conjugated equivalent estrogen or estradiol valerate also we can use. So all the three estrogens are quite okay. So you only know which one. If you are using ethylene estradiol, you cannot monitor the estrogen levels. You cannot monitor the estradiol levels. You have to only with the estradiol valerate you can monitor the estradiol levels for optimum estrogen maintenance. That is one thing which I want to tell. One more thing which I just wanted to add is any short stature with primary amenorrhea, Turner has to be ruled out. Chronic medical illness has to be ruled out. I have seen chronic kidney disease presenting as primary amenorrhea at 16 years, 18 years of age. Patients have undergone MRA pituitary, patient has undergone FSHLH, patient has undergone all sets of investigations possible without getting a urea creatinine done, and the creatinine is going to be 2.2, 2.4. They won't present with anything else except short stature and primary amenorrhea. So always rule out a chronic disease like chronic kidney disease, chronic liver disease, chronic lung disease before we go into the diagnosis of a combined pituitary hormone deficiency or hypogonadotropic hypothyroidism, some kind of fashionable diagnosis.
Abrina, that would also include a basic metabolic profile, which the hormone perspective I answered. So Dr. Bharat's point is very valid. So then you should definitely get a basic profile in addition to the hormones that I told you. That is thanks, Dr. Bharat. I actually completely forgot about that.
Most of the times patient comes to you as a workup patient.
I know.
But as primary caregivers,
Right.
and that we largely use equine estrogens, and then the secondary sex characters is quite good even with equine estrogens.
Thank you. For want of time, I really thank Dr. Shruti. That was excellent. And definitely, empathy is something we are lacking. We need to definitely, and it can be learned and it can be practiced, especially when you're giving a very serious diagnosis that can be affecting the child's future. Thank you so much. I would like to welcome Dr. Padma to felicitate Dr. Shruti.